Good evening. I am Dr. Jeffrey Sterling, Surgeon General of Alpha Phi Alpha Fraternity Incorporated, and it's a pleasure being with you this evening. On behalf of our General President, Brother Willis Lonzo III, and AARP, we'd like to welcome you to this very special webinar that we have. And I'll begin, by the way, we're going to be talking about health inequities in the African American community. So it's an exciting topic and one that I'm very pleased to be joining the panel on. But I'd like to begin the conversation by introducing just a phenomenal talent, an icon, and a very close friend, someone I get to work with every day. Dr. Carol Adams is, in fact, the former Secretary of the State of Illinois Department of Human Services, having managed the largest agency in Illinois state government with over 14,000 employees and a budget of over $6 billion. She's also the past president and CEO of the DuSable Museum of African American History, the oldest and longest running museum of African American history in the United States. I couldn't be more pleased than to have my friend and my colleague joining us. And by the way, she's an incredibly proud member of Alpha Alpha sorority. Her accomplishments would take up the entire hour. She is a phenomenon. If you don't know her, please Google her. She's living history, and she is the perfect person to moderate this panel for us today. So without further ado, welcome, Dr. Adams.
Well, good evening. It is such a pleasure to be here with a distinguished panel like this to talk about something that is so extremely topical and important to us as a people and important to our community. So I'm very, very pleased. I'm going to do the introductions rather quickly so we can get on to the business of the evening. So we have with us Dr. Inequalities. He is the Senior Advisor and National LGBTQ Liaison at the AARP, and also responsible for their Office of Diversity, Equity, and Inclusion. He has a long history as a social change agent. For one so young, you've done quite a lot in that arena and has been both in the academic side, the policy side, and the activism side. So we are pleased to have him join us and to be our corporate representative as we discuss the important issues of the evening. We also have with us Dr. Fred Earl Kinsey Jr., and he is a community emergency physician. So we're going to get a lot of emergency physician perspective tonight because we have both Dr. Kinsey and Dr. Sterling, who both have that expertise and who are really able to help us understand things from an insider's view. He is at the Baptist Hospital in Jackson, Mississippi, and an assistant professor of emergency medicine at the University of Mississippi Medical Center. He brings to us with him a lot of experience in this area. Again, he's a community emergency physician at the Baptist Hospital in Jackson, Mississippi. He's a life member of the NAACP. He's a member of the 100 Black Men of America and the American College of Emergency Physicians. Welcome, gentlemen. So without further ado, we're going to get directly into our conversation because we want to, at the end, make certain we have enough time for some exchange and for people to have a chance to ask some questions. So I want to know more about each of your roles and your functions when it comes to diversity and inclusion before we jump further into the evening's topic. So could we please start with you, Dr. Corte?
Thank you, Dr. Adams, and good evening to everyone. On behalf of AARP, I'm just delighted to be a part of this conversation organized by the Brothers of Alpha Phi Alpha Fraternity Incorporated. When it comes to diversity, equity, and inclusion, I think folks will be pleasantly surprised to learn that AARP is really turning up the volume in terms of bringing a DEI consciousness to our work throughout the organization. And so our CEO, Joanne Jenkins, recently, reorganized a component of AARP. We now have an Office of Diversity, Equity, and Inclusion led by Edna Kane Williams, our Chief Diversity Officer. Our office is focused on developing audience-specific strategies. We're reaching specific multicultural segments, including the African American community. as well as the LGBTQ community, the Hispanic Latino community, AAPI, American Indian Alaska Native. We're really pleased to turn up the volume on that. Age inclusion and advocacy against age discrimination is a part of this work, as well as getting our own house in order, keeping our own house in order with an internal initiatives team. And so that's how we've organized our diversity, equity, and inclusion work to touch the workplace, workforce, and marketplace. But parallel to that, we have a whole disparities initiative that I'm looking forward to talking more about. This initiative really germinated with the leadership of Brother Dr. Gene Axius, who is our Senior Vice President of Global Thought Leadership at AARP. He is also a proud member of Alpha Phi Alpha Fraternity Incorporated. Look forward to talking about that initiative that we are standing up to build equity in a way that centers some of the concerns, but also the opportunities to support older adults. I often say that now is the time, more now than ever, to begin to think about longevity differently, to begin to connect the dots and to really recognize longevity as a justice issue.
Introduction, as we think about health inequities in the African American community, we know that they have an origin from other inequities. And if we don't address those specific inequities, we won't be able to do anything about health, wealth, and economic opportunity, and housing, and all of those things. And so I'm interested, Dr. Kinsey, in what in your particular space, what you all are doing, what you tend to deal with on a day-to-day basis that involves inclusion and getting rid of these disparities.
Oh, thank you. As he said, I highly appreciate you having me on to discuss these very important topics. One of the most important organizations that I'm a part of as an emergency medicine physician is an organization called the American Academy of Emergency Medicine, which is the second largest organization that is for and stands up for emergency medicine doctors. Obviously, the largest one being the American College of Emergency Physicians, nicknamed ACEP versus AAEM. So that second largest one that I speak of, AAEM, American College of Emergency Medicine, just recently at our last board meeting, for which I'm a board member, created a committee for diversity and inclusion, which is a very important topic for us, because we need to have everyone having a seat at the table. If every person that we represent in our college, in our of emergency medicine physicians, doesn't have a seat at the table, that means that someone's thoughts, someone's beliefs, someone's things they care about aren't being voiced. Sometimes those things aren't being heard. Sometimes we don't even know that they're a problem because they don't have that seat. They don't have that voice. And so having this new committee being created, and I was very happy to be a part of this organization when this area was just a section, and then to become a complete committee where now it has a bigger voice and has a bigger seat at the table, means everything. This committee we've nicknamed JEDI, which is very appropriate for those Star Wars fans, stands for Justice, Equity, Diversity, and Inclusion. I mean, it's going to be a very powerful organization, I think, within our large organization of thousands of emergency medicine physicians throughout our entire country, and internationally as well. We have members in multiple countries. And so being able to bring those members to the table, their thoughts, their ideas, their complaints, their criticism, so that we can become a better organization and have a better voice for everybody, not just the ones who are just, in power.
Yes. Dr. Sterling, I want to bring you in this conversation because, there's always a lot of discussion about social determinants of health. I think there are also social determinants of wealth, and I think you have very brilliantly brought those together in some discussions that you're having and some of the things you're doing with Simcoe, Illinois. And I would just like it if you could share a little bit about how we address this at a macro level instead of every individual working by themselves to make a difference. What kind of differences can we make when we band together and work collectively? You're on mute, sir.
Thank you, Dr. Adams. The point I would like to start with is that I'm actually fascinated by the entire diversity, equity, and inclusion conversation, but I'm infinitely more interested in the equity part of the conversation. I find that too many of these existing efforts amount to whack-a-mole, where you find some type of inequity and try to address it. And the problem, more often than not, are the operational infrastructures on which these systems are built. And in our work around the world, we've discovered that to be the case, that if you actually are interested in these things, then diversity and inclusion are actually means to a specified end. The outcome that we all want is equity. Now, in terms of how you get there, the challenge before us is that you can't take these things in isolation. There are social determinants and social influencers of health, such as the basics, education, access to wealth, access to food, that really contribute, because as we all know, you can't be healthy if you don't have food, if you don't use food as medicine, if you're eating fast food all day, every day, or if you don't have access to health, if the cost of health is prohibitive. So all of those things are part of the consideration. And as far back as when I was in graduate school, as you know, I developed a model that was called Health and Human Service Center, in which the social determinants of health were brought to bear in a community-based center in a way that was applied to individuals to help them to become more empowered and ultimately better stewards of their own healthcare. As you mentioned in our work within Illinois with Simcoe, we are actually taking that to the next level to provide health by preventing disease before it gets to us, and by empowering individuals to have access, some level of equality of care, and to minimize the cost, all of those types of things that are prohibitive. So that's important. And I just want to frame the conversation that way, that it's just been too long for us to continue to aspire to be incremental in the way we move this thing forward. There's enough incentive for this country to pursue equity, because we are only going to be strong as our weakest link. And if the country is going to continue to grow and prosper, then we really need to have all members of society doing well. So let's talk about how that actually happens.
Okay, I like that framing. Let's discuss our terms a little operationally, so that people who are listening to us, we reach a common ground on how we look at diversity and how we look at equity. Because some people think that diversity is just somebody mixing, and every now and then you hear, well, here's the first African-American to do blank, or here's the first Black person to do this, and so forth. And it seems to put us in a position that is very narrow and isn't really designed to expand the role we play, and it's not designed to make us powerful. Folks say they've increased their Black folks at the hospital 100% because they used to have one and now they have two. So please tell me, what do you think of when you think about diversity? And I want you to tell me that same thing with regard to equity. What is being equal? What does it mean for us when we think about healthcare? Dr. Kinsey, you can take the first crack. So unmute.
I think Brother Corte was already talking. I'll let him get it first, then I'll come back after him.
Dr. Corte?
Sure. So, I was just going to say, there is a big distinction between equity and equality. And I think too often people use the terms synonymously, and they're not the same. Equal opportunity is not the same thing as in, equitable opportunity or equitable outcomes, right? And so, I think we need to be really clear about that.
That's why we want to hear and understand. Tell us the difference.
That's right. Well, I think, equality is about giving everybody the same thing, the opportunity to have the same thing, right? But part of what we have seen during the course of this COVID pandemic, for example, is that different groups of people need different things. When it comes to overcoming some of the barriers to getting vaccinated, for example, there are historical traumas. There are access issues that some groups of African Americans have had historically, compared to some of our white neighbors, right? And so that explains, why vaccination rates, it explains in part the difference between vaccination rates by race. When we look at, for example, the data that says that, now over 70% of, older Americans have received at least one dose of the COVID vaccine. Well, if we disaggregate that data by race, we see that for Black folks, it's not close to 70%. It's far from 70%, right? And so that's a tangible example of what it means to apply an equity lens when solving for some of the challenges in front of us.
I'm sorry, go ahead.
No, the only thing I would add to that, two things: no data, no justice, and we can talk a little bit more about that. But if we don't see different segments of our community in the data, then chances are the solution is not checking for them. Number one, and then number two, I just want to give a shout out to Rashad Robinson, the president of Color of Change, who often talks about the distinction between presence versus power. And this kind of gets to the comment that you'd made earlier, Dr. Adams, where I think sometimes we get stuck on historical first, right? And we should absolutely celebrate historical first. But understand that there's a difference between presence versus power. Somebody that's in a position to influence versus somebody that is a decider. And they're in the position to greenlight and to fund, and to hold accountable. And so, I think all of these things should be a part of our consciousness if we're serious about diversity, equity, and inclusion, heavy on the equity.
All right. So I'm hearing these distinctions, and they are so important and so instructive. It seems to me when you talk about the difference between inequity and inequality, you're also saying that equal opportunity may be everybody getting a chance, but in the equity lens, you recognize that everybody's not starting from the same place in this race. And so to achieve equity, some things you got to do more of in one place and less of in another.
Absolutely. And that means that, we have to look at redistributing resources differently. We got to look at budgeting differently. We got to look at hiring differently. We've got to do things differently. And so I think a lot of folks are a bit more comfortable with the diversity and inclusion part of the equation. But when it comes to equity, right, that really requires that you have a different modus operandi. And I think that's where you find folks sort of wringing their hands and throwing off, sort of some of the big decisions, because that's fundamentally going to get us where we say we want to go.
Dr. Kenzie, what would you add to that?
Yeah. So whenever I have a discussion about inequity, equity, diversity, inclusion, I think back on this picture I saw probably about 2 years ago. There's this picture of three people looking over a fence, or attempting to look over a fence to look at a softball game. Okay. And you can see the three people standing up. There's this adult, there's maybe a younger person, and then there's a child. Okay. And so there are different heights. And you have this wood fence in front of them. And at baseline, with all them standing on the ground, the adult can see over the fence without any help. All right. The two people under him cannot, because there is a barrier there. Well, you can give the two smaller people some step stools. And so now all three of them can see over the fence. Okay. Or you can just take the fence away, where no one has a barrier to the same thing. And so which one do we want? We want the one where no one has a barrier. We want the one where everybody has the same access and opportunities without anybody having to work harder, to step harder, to try harder, I don't want to have my child to have to do 4 times the work to get the exact same result.
Like
I want him to walk out and do the same work that his colleagues do and get the exact same result. And that picture is so, it touches you when you see it, and you like, That makes so much sense. It's one thing to give those other two people a little step up to help them get to where the other person already is. But how about we just take away the barrier? How about we just take away the wall so that you don't even have to, there's no wall, and I can just see the lane from the jump. So I think that's one of the most important and beneficial things to think about when you think about inequality. That how about we just help? I mean, how about we take away the income inequalities that increase obesity in the African American community? How about we remove some of the crime and things that increase the mental health issues in the African American community? How about we take away these barriers so that everyone can start off with the same slate and go to the same locations?
Well, a couple of times we've made reference to how these inequities are being borne out in the current pandemic. And I'd love it if you guys would discuss a little bit what we can do, what kind of interventions you are able to do where you are that make a difference in what we do. Because I think there's not just the issues of inclusion, but there's also cultural things that we have to think of and be aware of in our approaches and what we do. You know, Black people are not colored white people. We are people who have a culture of our own, and we need to take that in consideration as we are making policy and developing programs and interventions. How do you think we should approach this through a lens that has us looking at all that we bring to a situation to use it in our benefit? And I'm really thinking too about an asset lens, because we are taught to look at ourselves from a deficit position. It's always what we don't have instead of what is it that we do have that we can build upon.
So as you can see in our, like most people have talked about during the pandemic, during the pandemic, you could see that in the African American community, we had a much higher percentage of people who were in the service community, meaning that those people couldn't just work from home. You know, these are our waitresses, these are our waiters, these are our food service people. Those jobs aren't Googleable. You know, I mean, those jobs aren't home. You know,
you can't do them remotely.
Yeah, you can't do those remotely. Those people, when those jobs failed, they failed. They had nothing to back up on. They couldn't just go home and work from a computer because their jobs were manual labor. Okay, so what can we do to prevent this kind of thing from happening in the future? We can get more people into positions where that's not the option for them. You know, we can get more people into jobs through Job Corps, through other avenues, where if we have another, you know, coronavirus pandemic, we don't have so many people that lose their jobs because they have no other options.
Dr. Sterling, what are some other ways you think that we can, some other initiatives that you think we might be able to affect that would impact the current COVID situation?
Well, I've been listening. I respectfully would suggest we have to aim a little bit higher than even what's been discussed. I think that healthcare and the production of healthcare outcomes is not going to be based on equal access and equal opportunity. I think the goal is not starting from the same place, but finishing at the same place. And the COVID-19 pandemic is an excellent example of that. I think that partially, even if the vaccine had been offered to African Americans early in the process, as it should have been because of the comorbidities that we have that produce worse outcomes, we would have been reticent to have gotten vaccinated. So equal opportunity in that example wouldn't have produced equal outcomes. We really have to do extra to ensure that we're data-driven on the front, as Dr. Corte mentioned, and that we're outcomes focused on the back end. So the best way to do that, very simply put, public health data is very clear that the very best healthcare outcomes are produced by culturally sensitive and culturally specific providers of services. And what that means is that members of the African American community need to be empowered. We need to be present as trusted messengers, and we need to be involved every step of the way, as was often the case here in terms of providing research, developing those vaccines, being part of the studies is what I said. And also along the way, getting the physicians and the nurses and other healthcare providers up front and center in these communities that are at high risk, so that there's a level of understanding that is able to combat levels of fear. So as we've done with Simcoe, as you know, Carol, we've done vaccinations in Atlanta and DC, Chicago, Houston, and we're heading to New Orleans. It's made a difference when we are out there on that wall providing information to individuals who would otherwise be skeptical or reticent. When they see us on that wall, that matters as much as any piece of information that comes from the CDC and the FDA. So this goes back to, once again, not just our presence and our participation, but both equity and equality in delivering messages and participating in the process that is meant to provide equal outcomes at the end of the conversation.
The data also shows us that our people get better care from us.
Right.
So our numbers have to increase so that can happen as well. And I'm wondering about initiatives, or we might want to discuss at some point, initiatives to increase the number of us who are in this field. You know, you mentioned, Dr. Corte, also increasing people who are participating in certain things so that the data is reflective of us and our habits and what have you. I'm assuming clinical trials and things like that. In your work at AARP, are you all taking a look at things in specific fields like healthcare, or are you looking mainly at employment as the entryway to equity?
Great question. I think we are looking at a lot of different pathways towards building equity, and there's a little bit of feedback there. There we go. We're looking at a lot of different pathways towards building equity, and I just can't underscore enough the importance of not just the message, but the right messenger. And I think we've seen that make a huge difference throughout the pandemic. Having African American physicians, African American public health officials, African American civic leaders, and organizations like Alpha Phi Alpha Fraternity Incorporated that have been out there disseminating vetted information from trusted sources. AARP has made it our priority to be a disseminator of information as a trusted source, right? And so anybody here and anybody listening can go to aarp.org/coronavirus for the most up-to-date information on all things related to the COVID vaccine. We update these pages on a regular basis. So whatever state you live in, we have information that's specific to your state. And we work very hard on that. But I also want to go back to something that was said about some of the essential workers, in which case our community makes up a substantial number of folks classified as essential workers. We've got to make sure that we are showing up for them in some really significant ways. And so, AARP is a part of a wide coalition of folks that are currently pushing right now on Capitol Hill for paid leave. And there's a proposal on the Hill right now for 12 weeks of paid family leave. That would make a very big difference for everybody, but particularly essential workers, gig workers, part-time workers, right? That had to go to work and to put food on the table during the course of this pandemic, and also put their own health at risk. It's also been mentioned during this conversation, the comorbidities, that our community over-indexes in terms of comorbidities that have made us particularly at risk during this pandemic. Well, that's part of the reason why, AARP has been pushing so hard to lower the cost of prescription drugs. We don't want anybody to have to choose between, dinner or filling their prescription. And so those are some concrete ways in which we are really working hard to make a difference, recognizing that folks are affected by these issues differently. And when it comes to the Black community, we are disproportionately impacted when it comes to the cost of prescription drugs, when it comes to the difference that paid family leave would make, particularly for those that are essential workers. And so partnering with the right messengers has made and will continue to make a big difference as we begin to emerge from this pandemic.
Well, I'm happy to hear you talk about policy changes. It's really important that we look at that as well and think that things are not just episodic or may be a problem in one place or another, but that we have public policy in this country that contributes to sort of institutional inequities. So we have to look at what we do there and how we impact and how we address our elected officials, if you will, in terms of representing us around policy changes. Are there specific policies you think we should be looking at if we want to improve our outcomes that really impact us when it comes to our health and our wealth? This question is to the entire panel.
Yeah, I mean, I think there are a number of policies out there, and I've just named just a few of them. Paid family leave, and investing more in Medicare. Allowing Medicare to negotiate with the drug companies to lower the cost of prescription drugs. I mean, these are policy changes that are currently being debated on Capitol Hill, and where AARP believes we're on the right side of these issues. But I'd also be remiss if I didn't mention the importance of the Equality Act. The Equality Act would amend the civil rights, landmark civil rights legislation to include LGBTQ folks as well. And AARP has not been shy about coming out in support of the Equality Act because we believe it's the right thing to do and that everyone deserves to be afforded dignity under the law when it comes to housing and public accommodation and every facet of American life. And so those are just a few policy changes that I think would make a big difference in our community for various segments of our community.
Dr. Sterling, what do you think? Are there some specific policies you think we need to advocate to change? Some practices that are happening?
Yes, there are two. Once again, I want us to avoid the risk of playing a very effective game of whack-a-mole where we nibble at the edges of a system that has a rotted infrastructure. There really are two things that I would actually suggest from a public policy standpoint. And the first is really looking at our system and ensuring that there are essential healthcare services that are being provided to all members of the society. And again, that is not socialist medicine. That's not even necessarily modifying the capitalist nature of our existing system. However, it is folly to think that we can simply wait for people to get sick and then show up at an emergency department and somehow believe that that is a healthcare system. That doesn't work. And one of the things that the Affordable Care Act did for the first time was to actually introduce some considerations that eligible individuals would have at their disposal, making that the law of the land across the board really would do quite well, because the return on investments on some very fundamental and basic things is where we need to go. The second, and the one that involves my work prominently, is really focusing more on prevention, health prevention and health promotion, than on curative or sick care. Once again, as we say, stay ready so you don't have to get ready. The long and short of it is that an ounce of prevention will always be worth a pound of cure. And our work around the world with Simcoe and elsewhere, and the very existence of the Surgeon General Initiative and Alpha Phi Alpha, is all about giving individuals information that empowers them, allows them to be better stewards of their own healthcare, and shows people very simple things that can be done that actually have huge impacts. And implementing and rewarding that, aligning our public policy with those types of considerations, would help the United States produce better healthcare outcomes than it does now, when in fact, with all the money that we spend, we stay ranked in the mid-30s compared to a lot of other countries that score much better than us, spending a lot less money, primarily because they begin the conversation by building a proper infrastructure that includes health promotion and preventive health considerations. So those are the two things that I would point to.
Okay, I think that's very significant. I think it's sort of an appropriate segue, because we've talked about the infrastructure, we've talked about discriminatory practices, we've talked about a lot of things. Let's talk about us. Let's talk about what critical changes need to be made in our own communities and by individuals. Where does the individual fit into this space? And what can we do to empower ourselves? What do you think, Dr. Kinsey? You're on mute.
Okay. I'm a huge proponent, and you can ask my wife, of personal responsibility. Okay. Um, Obviously, there's a lot that we can do as a people to help other people, but in itself, we also have to remember that there is some personal responsibility that comes with uplifting you as a person and then us as a community. I can't tell you how many times I've gone into the ER and saying, tell me about your medical problems. What medications do you take? When was the last time you had a refill? Oh, it's been a couple months. Well, why? You're on a program through our hospital that pays for your medication. You don't even pay for these medications. Like, we pay for them, and there's still no answer. So a lot of times it's having that conversation with people to try to get them more motivated to take care of themselves, to be around for their children, their grandchildren, to be around for their family members. Because I can't tell you how many times, we have to truly empower the person to just do the right thing for themselves. It happens more time than not.
Well, Dr. Kinsey, let me ask you this as a lay person, and anyone else can respond. I think that we have a love-hate relationship with medications. Okay. When you see the advertisements and the things about the medication, and everybody tells you stay away from that medicine, it's going to make you sicker, or it's going to cure one thing and cause another. So, and then they tell you, hey, take this, you'll feel better, but you also have diarrhea and want to kill yourself. Then what makes you want to do that? I mean,
true. And that's the conversation with your physician. I've had this conversation, especially through COVID, hearing about, the most common one, the Johnson & Johnson vaccine. So we know that through literature, through data, the Johnson & Johnson vaccines has a very small risk of causing a specific type of blood clot that can happen, and it can make your platelets become very low. Well, we've seen this phenomena in maybe 20 people out of 100 million. Okay. But the 100 people, that get the issue, even though the 100 million vaccines has saved 100,000 lives. Is any medication totally safe? The answer is no. One of the medications that is sold over the counter that I've had as a true toxin for multiple people is Tylenol. A lot of people don't know it, but Tylenol is one of the most toxic medications sold over the counter. When Tylenol is taken in an excessive amount, it can cause liver failure, and it can be fairly rapid. And those people, and we have great medications to treat it early, but if it takes too long, then there's nothing we can do beyond a liver transplant. So there's always going to be any foreign object you put in your body, there's the possibility that something bad can happen from that medication. But in medicine, with FDA's help and lots of scientists and lots of companies that are devoted to keeping us alive and keeping us around, the goal is that we create medications that have more positive aspects than they have negative. And you want that to be a huge swing. You want it to be a huge positive over a very small negative. And that's what we have most of the time. We have blood thinners that prevent us from having strokes when we have different heart abnormalities. Well, those blood thinners, if you get into a major car accident, will also mean that you are going to bleed a little bit easier than you would have had you not been on it. But the number of people who would die in a car accident on a blood thinner versus the number of people who would die from having strokes and other neurological events from this abnormal cardiac event, through lots and lots and lots and lots of data, is shown that it is more important and is better to be on those blood thinners. So that's why it's important that you listen to your physician, that you get your data from reputable sources, and that you participate in your own medical care so that you know what is best for you. It's not about what's advertised on the TV screen, because that's not, the TV isn't made to promote health most of the time. Those commercials are paid for by lawyers. Those commercials are not paid for by people who have your best interests at heart. Those people are usually attempting to get some type of financial gain from that commercial. Those commercials aren't free. So they're not doing it because they just like you. They just like to get information out.
Well, those commercials are backed by big pharma who want you to start asking for specific medicines. And I'm thinking about Dr. Sterling's comment that food as the best medicine, as the best preventer, us really focusing on prevention. We need the marketing to be as strong about that as it is about taking medications. We are very oriented to what you do after you're sick.
True.
That 9 times out of 10 is going to make you sicker. So how do we shift this paradigm and start a better level of marketing in our communities and beyond when it comes to preventive behaviors?
We have to reach the youngest. That's honestly, we have to get down to the youngest of the young. My wife is a pediatrician, and I can't tell you how many times we've had conversations where she's got a 10-year-old, a 9-year-old already on antihypertensive medications.
Wow.
At 10 years old, they're already on blood pressure medications. At 10 years old, they're already on diabetes medications that, 20 years ago, that was a 30-year-old, 40-year-old, 50-year-old person's drug. And now we're seeing 10-year-olds taking these medications. And the way that we prevent it is that those 10-year-olds aren't going to McDonald's on their own. They're not walking to Burger King. They're eating the product of what's going on in the house. So it's easy to say fix the kid, but the reality is we have to fix the adults, because they're the ones that are bringing in these bad situations. They're bringing in these bad issues into the home. The poor diet, the lack of exercise. All these different things. They're the ones that are doing it. So it's a double hit. We have to really preach it to the adults, but we also have to have the pediatricians preach it to the children. We have to have programs in the community where kids can actually get out and do things that are healthy. And
in their schools,
sports or soccer. Yeah, and you look at it, you have all these schools that are taking away sports because of financial inequality. So these schools can't afford a football team. They can't afford a soccer team. But these are the things that are getting these kids the little bit of athletic time they have, throughout their entire day. These kids aren't going to gyms. So this is the little bit of time they have to work out is in their schools through their soccer programs, baseball, football. And those are the first programs that are cut when it comes time to budget cuts in some of our communities. I can tell you,
but the food is bad in the schools too.
Food is horrible. It's horrible.
And
in some schools, in some schools, but we got to put our asset lenses on too. In some schools, the food is actually getting better, and the nutritional value in food is getting better. In some places, not enough places, but in some places, before AARP,
what's driving that, Dr. Corte? What's making that happen?
What's that?
What's driving those improvements?
There is so much movement building work that's happening. Addressing some of the root causes of childhood obesity in the country, whether we're looking at healthy food financing initiatives, or we're looking at the reforms of shared use policies where schools are open after school hours and on the weekend, so that folks in the community have a safe place where they can go and play. Whether we're looking at screen time. And monitoring screen time on devices. I mean, there are so many root cause issues that have disallowed America's young people to be able to achieve a healthy weight. And so hats off to, lots of groups out there, the Food Trust, Safe Routes to School National Partnership, the NAACP. I mean, there are so many organizations out there doing incredible work. But, that really brings me to a point that I wanted to share earlier. Around longevity. There's a book out called The 100-Year Life. And, it's pretty interesting. Would encourage folks to take a look at it. But I think one of the blind spots in that reading is considering that a number of us, particularly in the Black community, don't have the same opportunity to live a 100-year life. And so that's why at the top of this conversation, I mentioned, how we all might want to look at longevity as a justice issue. Some of the issues that are affecting our young people. We heard Dr. Kinsey's, talk about, his wife having to prescribe hypertension medication to, young kids. Well, if that goes unchecked, unmanaged over the course of a lifetime, by the time they're ready to join AARP, their membership might be short-lived because they might not be able. They may not live a very long life if those issues are unchecked. And so, self-care from the neck up and the neck down. I'm talking about mental health and physical health. I think that's a part of what we can do as individuals and as leaders in our communities. I think being engaged in community makes a tremendous difference, and not just online communities, but offline community. Our civic organizations and our churches, are places where we can do that. And then last but not least, getting the facts on issues that are impacting our community and amplifying fact-based information among our friends and families. I think these are just a few things that we can do as individuals that will collectively make a big difference in our communities.
Okay, I think those are all excellent. I wanted to also toss that to Dr. Sterling to ask you as we're sort of winding down so we can open up for some questions. If there was one particular suggestion, if you were only able to make one that you thought could make a critical difference for us and for our outcomes, what would that be?
Well, if the question is one, then you need to focus on preventing illness instead of worrying about how you're going to treat it. It's not more complicated than that. Waiting for sick care and an emergency department solution is not in your best interest.
Prevention lens.
That's right.
Dr. Kinsey, anything you want to add? We heard a number of actionable things from Dr. Corte. We also heard about a prevention lens. You talked about habits and lifestyle and things that need to come from the adults to lead the way for their young people. Anything you want to add to that prescription?
No, I totally agree with Dr. Sterling on the preventive portion of it. I mean, so many of our disease processes can be prevented, rectified, completely eliminated if we took better care of our bodies early and didn't wait until the disease process presented itself. So prevention is key. Getting the education out to be more adept on how to prevent is important. Educating the children so that they can go home and say, well, Mom, maybe we shouldn't eat a cheeseburger tonight. Let's do salad. Those kind of things will help as well. But prevention is definitely our biggest key to getting our community where it needs to be.
And you're right, kids do take messages home.
Yes, they do. I have 3 of them. Bring them home all the time.
Yes. All right. So if anyone who is listening to us has a question that you would like to raise with the panel, please put it in the chat, and I'll be monitoring that for these next few minutes so that you have a chance to get in the conversation. I've been looking at things that people are saying. Most of them are talking about what an important discussion this is for us to have at this time. Others have asked more specific things like if certain medications like Tylenol are actually problematic, what do you suggest people take instead? I don't know whether this is a forum where you would want to do that, but people are looking at if you have arthritis, if you have some other things where you've been told that this is what you should take, what are some other options? What are some things you can do?
Yeah, understand that I mentioned Tylenol when taken in excess. So taking at the appropriate doses, Tylenol is fine. but it is easy to overtake any substance that we do, just like it is alcohol. It's easy to overindulge and become intoxicated. With smoking, it's easy to overindulge. And with Tylenol, it's the same thing. When taken in excess, it can become very toxic to the body. But when it comes to just general aches in the body, there are multiple medications for pain relief, to include the anti-inflammatories, things like naproxen, things like ibuprofen. So there's lots of options out there where we don't have to use Tylenol all the time, and understand that even those medications, even aspirin, when taken in excessive amounts, can be toxic. And that comment earlier was only to show the example, because it was initially mentioned that there's these commercials on TV that talked about how this medication can cause this problem. That discussion was only to show that there are lots of medications, even ones found over the counter, that can cause problems. So it's not just the medications that physicians prescribe that cause patients ailments and illnesses. Anything that you put in your body, whether it be prescribed or just bought over the counter, things that you see over the counter, like, horny goat weed, yohimbe, caffeine, any of these things, when taken in excess, can be more detrimental than they are beneficial. So understand that it's not a problem to take Tylenol. It's not a problem to take any medication that is legally allowed to be sold in a store, but understand that when taken in excess, it can cause issues as well.
All right. Well, someone raised a question of this when they talk about policy, and that is, why don't policymakers and legislators, who always have to look at budgets and balancing budgets and what have you, not understand and see that it is so much more expensive to practice the sick care that we're practicing instead of preventive care? What has to be done to make them get it and be willing to spend dollars differently?
A piece of it, I think, comes from the idea that their term is 4 years or 6, depending on what they're running for, is that, they have their quartet of people that they're trying to appease. And it's easier to appease the person today than it is to appease the person, who you're trying to technically appease 15 years down the road. So, I'm not a politician, and I don't hope to ever be a politician, but I do understand that when you're running for something, you're technically trying to appease the person in front of you, not the person 15 years down the road in which you may not be in office anymore.
So you think more pressure tactics from the public and from people like yourselves to legislators would be in order?
Definitely, and then that's what it takes. And we have organizations out there like AARP. I was telling Doc a little before we started this, I'm a member of AARP. I'm a 37-year-old male, and I've been a member for the last, probably 7 years. I've been a member for the last 7 years. So I get the emails every day. I get the emails and the booklets all the time. And they're always pushing the health initiatives about healthier eating, healthier this, and within that, talking to your politicians about programs that can introduce healthiir eating, healthier habits. But at the end of the day, those politicians are trying to appease the person who is in front of them. So if the person in front of them is a little bit louder and they want their issues handled today versus the issues that can actually, objectively be seen as fixed 15 years down the road, it's a little bit different.
So who will lobby for the people? Dr. Sterling, who will lobby for the people on behalf of the people? If pharmaceutical companies and others who have a vested interest in sick care have strong lobbyists who put themselves in front of politicians and legislators, who will lobby for the people? You're on mute.
Let me address that in my closing comments. I want to toss it back over to Dr. Corte and get his thoughts on this before we have to wrap up.
Right, because we're close to there. So Dr. Corte.
Sure, and thank you, Dr. Sterling. I will keep it brief in just saying that just how healthy living is a lifestyle. Civic engagement is also a lifestyle. And I'm beaming in today from Washington D.C., and there is no shortage of activity inside the Capitol, but as well as outside the Capitol, where there are lots of groups, including but not limited to AARP, that are highly engaged with what's happening on Capitol Hill, highly engaged with what's happening at the White House, but also state houses across the country. Just as much as the federal government, and their decisions play a role in our everyday life and opportunities that we see in our everyday lives, so does our state government. So does our local mayors and our local city councils. When it comes to public safety and keeping our communities safe, we're reimagining what public safety looks like. And so, we can't leave it to somebody else to advance the interest of we the people. We the people need to make our voices heard. We need to engage civically in our communities because this is a marathon. It's not a sprint. It always has been.
It's a long distance run.
Yeah, absolutely.
Well, I want to thank AARP for sponsoring such a significant discussion and for really being in there in the fray, trying to make some difference and trying to make some important things happen for people so they can be members longer, so that the longevity becomes a focus here. And I also want to commend the Alpha Phi Alpha Fraternity, my brothers, for being so forward thinking and engaging in a partnership and engaging in these discussions that keep people current and informed. And on that note, I think I'd like to ask the Surgeon General, the first Surgeon General, I might add, of Alpha Phi Alpha Fraternity, if he would close us out, wrap this all up in a bow so we know what to do henceforth and forevermore. Dr. Sterling.
Thank you, Dr. Adams. As always, it's a pleasure to be with you, and thank you for steering this conversation for us. The message that I want you all to take home with you is actually quite simple, and your last couple of questions actually pointed in a specific direction. We are the answer that we seek, folks. We talked a touch about personal responsibility, but I'm here to tell you that that's on a macro level, and that's not going to get it done by itself. We need nothing less than a transformative approach within our community. We, quite frankly, have to stop worshiping some things that translate into bad healthcare outcomes and start embracing things that we know to be best practices in producing healthcare outcomes. We have to, as was pointed out, learn to advocate for our own interest instead of depending on those who would practice good government to do so for us. We need to be aware that the United States does not have a healthcare system as much as it has a healthcare industry, the purpose of which is to exchange commerce amongst businesses. So there's a lot of work to be done, and there are many organizations, and I'm proud to be involved with several of them, and very proud to be sitting here with the AARP, reaching out in that same direction. But to everyone that is within reach of my voice this evening, you really have to accept the challenge, not just for personal responsibility to do things that you know to be best practices, such as to eat better. Food is medicine. Everything you put in your mouth either helps you or hurts you. To engage in activity. You don't need a gym membership to take a walk or to do things to get your heart rate up. To lower your stress, to surround yourself with positivity. Just those three things alone, if you did that, would significantly improve the quality and the quantity of your health. We have to transform our community to where we actually advocate for our own interests, become stewards of our own health care. That is what's necessary. And as I've said before, anything short of that really is whack-a-mole and just serves the purpose of continuing to support an operational infrastructure that is in fact institutional racism and systemic racism. And let's just be aware and let's just do better so that when we aren't as dependent on getting sick and trying to hope that we can be better subsequently. I want to thank everyone for participating this evening. I want you all to join us again this same time next week, where the topic will be mental health. And on behalf of Alpha Phi Alpha and our General President, Willis Lonzo III, I want to wish you all a great evening and hope that you all stay well. Good evening.